Welcome to the virtual Zero Prostate Cancer Education and Support Summit. I'm Jeremy Patch, Zero's Director of Patient Programs and Education. We have two exciting live panel discussions for you today. Coming up in just a minute, we're discussing the importance of genetics in prostate cancer with Dr. Alexandra Sokolova and Justin Lorentz. At 2 p.m. Eastern Time, it's an Ask the Experts Q&A panel with Dr. William Jackson and Dr. Randy Vince. We want you to be part of these discussions, so email us your questions at education@zerocancer.org. Be sure to include which panel your question is for in the subject line. Please remember to keep your questions general, as our panelists will not be providing medical advice. Let's get right to our discussion on genetics. I'd love to tell you a little bit about our experts. Dr. Alexandra Sokolova is an assistant professor of medicine in hematology and medical oncology at the Oregon Health and Science University School of Medicine. Her research focuses on helping prostate cancer patients and those with hereditary cancer syndromes to live well. Justin Lorentz is a certified genetic counselor through the American Board of Genetic Counseling. He practices clinically at the Sunnybrook Odette Cancer Center in their Cancer Genetics and High Risk program and is an instructor at the University of Toronto. Welcome to you both. We've got several things to discuss here, and I know genetics is such an important and sometimes confusing topic, so I'm grateful for you joining us today. So Justin, I'll start with you. What is the difference between germline and somatic or tumor testing? As we know, there are some different names that come about with these.
Yeah, it's a really good question. Whenever a patient tells me that they've had genetic testing, my next question is, okay, well, what kind of genetic testing have you had done? In today's world, there are multiple types of genetic tests that are commonly done. 10 years ago, there's kind of just one that we were thinking of. And so the two main genetic tests are genetic testing of the tumor itself, so the cancer itself, and then genetic testing of what's called the germline. So I really want to start with the germline piece to that, because it's a bit of a jargony word that I would love to really be a household term that we use. Just like we use the word germinate on a regular basis, I feel like germline can fall into that same bucket eventually. So germ is the Latin word referring to seed or a bud or an embryo. So things like germinate, wheat germ, all come from that. And so germline testing looks at genetic changes that we inherit from either the egg or the sperm that fertilizes the egg, and that makes us who we are. Germline genetic changes are rare. They don't happen very often. Very few families have these genetic mutations that are passed on from generation to generation. It only accounts for about 10% why cancer happens. And so when it comes to these, where the sperm does fertilize the egg, and if there's a mutation in either the sperm or the egg, that means that the embryo and the baby that develops with that has a mutation in every single cell in their body. And so when we do germline genetic testing, we can test any cell in the body. It's just that we typically like blood and saliva because they're really easy tissues to access, and we can extract the DNA from that. But we could take a skin biopsy, we could take an eye biopsy, but all that stuff's pretty invasive. So we just use a saliva sample or a blood sample. When we find a genetic change in the saliva or blood sample, we just assume that that's present, that genetic change is present in every other cell of the body. As a result, if someone has a germline genetic mutation, it could impact more than one tissue. So we think of, the genes that are commonly associated with prostate cancer may also be associated with breast cancer in men, pancreatic cancer, because those are other tissues, because other cells also have that genetic mutation. If someone has a germline genetic mutation, they've inherited it from the sperm or the egg, so they can also have a chance of passing it on to the next generation. Genetic testing companies that do germline testing are companies like Invitae, Myriad, Color, Ambry Genetics, GeneDx. The long-winded answer for at least one part of this, the other one I want to get into is the tissue testing, the second type of genetic testing that we do. This is called somatic testing. It's called tissue testing. It's called tumor testing. And essentially what we're doing is we're looking at the cancerous tumor itself, or the specific tissue, to see what mutations are present there. And when it comes to looking at the mutations present in the cancerous tissue, we will find so many mutations. And that's because all cancer is caused because of multiple genetic mutations. And interestingly, if we were to take tissue right next to the cancerous tumor, the healthy tissue, we would find no mutations, unless there's a rare instance where there's a germline mutation, all tissues impacted. But typically, if we find a whole bunch of mutations in the cancerous cell, healthy tissues next to it, healthy cells next to it, we won't find anything. And so the reasons why we do this type of testing, the genetic testing of a tumor, is to see, hey, if there are certain mutations, are there certain therapies that can target those mutations specifically? The results of a tissue test or a somatic test just are helpful in managing that cancer. They don't have impacts for other family members, largely. And so companies that do types of tissue testing are companies like Polaris, Decipher, Oncotype DX. And so the germline looks at things that are inherited that increase risk because there's genetic mutations. And then somatic testing is just looking at the cancer itself to see if there's any mutations that are there, or what types of mutations are there, because there's always mutations present. Long-winded, but it's a tough, simple question, tough answer.
Yeah, no, well, thank you for that distinction. That was helpful. So Justin, back to you. Who should consider germline testing, and what do the recommendations and guidelines say?
Yeah. And so the answer of who should be considering germline testing is pretty complex as well. In the world of prostate cancer, there's one really big factor that makes us think, hey, we should be looking to see if there is an inherited risk of germline genetic change that might be associated with that person's risk. And that is what's called metastatic prostate cancer. So a prostate cancer that's spread to other parts of the body. That is a pretty well-known indicator. And in individuals who have metastatic prostate cancer, about 11 to 12% have a genetic mutation, which is a high chance in the world of genetics. And so anybody with metastatic prostate cancer. Now, there is this guideline called the NCCN, National Comprehensive Cancer Network, that makes rules for when we should start thinking about people getting genetic testing. And they came up with a fresh set of rules as of last month. And so metastatic prostate cancer being one, and then individuals who have certain types of specific types of cancer, ones that are considered to be high risk or very high risk. If there's something called an introductal component to cancer, that's a factor that we think about as an indication for getting genetic testing. The other thing is family history. So if an individual has prostate cancer and they have a family member with a triple negative breast cancer, with breast cancer diagnosed at or under the age of 50, an individual who has in the family who has male breast cancer, an individual family with ovarian cancer, an individual with pancreatic cancer, another individual with metastatic prostate cancer. All of these aspects of family history in the context of someone being diagnosed with cancer themselves, prostate cancer themselves, are indications to start thinking about doing germline genetic testing. We also know that individuals of Ashkenazi Jewish ancestry who have a personal history of prostate cancer, good indication for genetic testing, because individuals of Ashkenazi Jewish ancestry are 10 times more likely to have a genetic change in the germline than people who are not of Ashkenazi Jewish ancestry. So the NCCN is a pretty commonly used guideline, but a kind of a universal guideline across the world of metastatic.
Oh, can you speak up? Okay. We just lost your volume there for a little bit, just at the end.
The metastatic prostate cancer is the internationally the criteria for thinking about genetic testing, but there's some more refined criteria in the US.
Okay, great. Thank you. That's really helpful. So Dr. Sokolova, now that we've discussed germline testing, so who should consider tumor or somatic testing? And similarly, what do the recommendations and guidelines say?
That's a very interesting question. I think when we think about who needs to get testing, it's important to ask, why are we doing that? And I would say that germline testing has overall a broader implications for why we test it. One of the implications that is shared with somatic testing is treatment implications, but it also has a broader implications. It has other cancer screening, it has family implication, it has prognosis implications. When you think about somatic testing, I think the kind of largest implication of somatic testing is treatment. So everyone who the somatic testing could change treatment for should get somatic testing. The NCCN guidelines do recommend somatic testing for our kind of BRCA-like genes for everyone who has metastatic disease, because we have treatments that we can use if we find those genes. It does say consider this testing if people have a regional disease, meaning it's advanced but not really metastatic yet. And that's because there could be some implications, some clinical trial implications, or a large proportion of those patients will progress to becoming metastatic, and knowing those mutations early on can help us to plan treatment. When we talk about the second set of mutation that we test for, such as microslide instability or mismatch repair deficiency, kind of our Lynch group of alterations, NCCN guidelines do recommend it for everyone who has metastatic castration resistant and considering it an early disease space. So as a blanket rule, everyone with metastatic disease should get somatic testing. And it's not somatic or germline. People with metastatic disease should get both because they provide a little bit of different testing, a little bit of different angle. And so if someone qualifies for both, they should get both. I would also say that now with so many clinical trials available, there could be opportunities for someone with a localized disease or a regional disease to be part of a clinical trial. So if they're centrally treating, there's a clinical trial kind of targeting this specific population, your doctor might be talking to you about doing this testing even earlier on. But as per guidelines, kind of standard of care, everyone with metastatic disease should be thinking about somatic testing. I think it'd also be important to talk about kind of how we do somatic testing and what it is, because there's a little different flavors of somatic testing. When we talk about somatic testing or tumor testing, we want to see which mutations happen in the tumor as tumor was developing. And we can test it by either taking the tumor tissue itself, so biopsy, and that could be a biopsy that was done earlier and stored somewhere in archives, and we can retrieve this biopsy and look at mutations, kind of the original biopsy, or we can do a fresher biopsy, newer biopsy, and we often go for a metastatic site. And the nuances there with an older tissue or older tumor sample, we see kind of an earlier developments in the cancer. So we see mutation the cancer had earlier, and sometimes over time, the DNA or what we test degrades, and we're not able to get a good enough of a rating. The rule of thumb is probably anything over 10 years old might have some limitations of testing on it. So anything within the last 10 years, we can try to test and see if we find what we're looking for. And so if we're looking into the fresher tumor biopsy sample, it gives us a fresher tissue, so probably high chance of successful testing. It also gives us a kind of a later clone. The cancer evolution, it starts as something, and then as we treat it, it develops into, it migrates and evolutionizes to adapt to live through treatments we have. So it develops new mutations and develop new alterations. So by biopsying a fresher or kind of newer metastatic site, we're probably looking at a snapshot of a later tumor clone that might be more relevant to treatment right now. We also have a different method of doing tumor testing, which is circulating tumor DNA. And that's a more newer technology that we've been using. And tumor kind of sheds some of its genetic material in the blood, and we now have technology to pick it up. So we don't necessarily have to do a biopsy. We can just do a blood test and then look for tumor DNA in the blood and do genetic analysis on it. It also has some limitations because you do need to have a certain tumor volume to pick it up, this DNA, because if it's just a little bit DNA, it might be hard to pick it up. It does correlate with the PSA levels. So the higher the PSA numbers, probably the more of a tumor volume, the more of a tumor shedding, and the higher chance will actually be able to pick up something in the blood. It does also give us kind of a later snapshot of a tumor, kind of later mutations. But when we talk about tumor testing, we think about, are we going to do an archival tissue? Are we going to do a new biopsy? Or we're going to look at just the blood DNA? And there's no rule of thumb. I think it's very individual, but I've kind of shared some of the considerations we do.
Okay, great. Thank you for that. So really, patients, if they're wanting which test might be right for them, another biopsy, testing the older biopsy, whatever, it's just they should talk to their doctor about that then. Great. And just to reiterate, you did say, if I heard you correctly, that metastatic prostate cancer patients should get both germline testing and somatic testing, correct? I think that's important. I just want to highlight that again.
Yes, thank you for highlighting. I think this is something that's sometimes gets misinterpreted or missed because, well, you did one test, why do you need the second one? The genes are everywhere. But yes, you're right. If you do germline testing or if you do somatic testing, you would be getting DNA, but our tests are designed for different purposes. And then they should be used appropriately. So if someone is qualifies for both, and everyone with metastatic does, they should get both tests done.
Great. That's an important point. Thank you. So Justin, what is the process for getting genetic counseling or testing?
Yeah, and so I guess the caveat here is that we're going to speak to the germline process of the genetic counseling and genetic testing piece. There's a few different ways that people can access genetic counseling or genetic testing. And the reason why I differentiate them is because not everybody who gets genetic tested may do it through a way where they meet with a genetic counselor. A genetic counselor is someone like me. I'm not a physician. I am a genetic specialist. My skills are to interpret genetic test results, explain genetic test results, facilitate genetic testing. And oftentimes the gold standard of how our profession says we should be doing this genetic testing process is to meet with someone right up front and say, hey, we could do genetic testing to look at the genes that you've inherited, to see if there's any genetic versions of those genes that might increase your risk for cancer, why you got cancer. And then the reason why we have this counseling piece is because we say, hey, if we find that you have this gene mutation, it could have implications for you and for family members. So after we have that conversation, and I'll talk a little bit more about what the implications of a germline genetic test can do, but after we have that conversation, we facilitate the genetic testing. The genetic testing comes back. We have a conversation, a post-test counseling discussion to talk about the results. Now, the way that this process happens, traditionally, it was through a referral process where you get referred to meet with a genetic counselor to facilitate that testing by your doctor. Now that genetic testing is happening so much more often, there's so many more indications, there's such high volumes, we're changing our models of care. Instead of us doing this ideal scenario where you meet with a genetic counselor before doing genetic testing, that's not feasible as much anymore. So now the models are changing where maybe somebody will do an educational video and their physician will initiate the genetic testing process. And maybe after the physician orders the test, the result comes back. You may meet with a genetic counselor depending upon the result. Sometimes you automatically meet with a genetic counselor. It depends upon what the model is that the institution that you're working with uses. Other ways that people can access genetic testing is right through a company like Color. They don't need a physician. They can order the test themselves, and they'd be paying a fee for that. And then they would get a saliva sample sent to them by mail, send the saliva sample back, get a report back, and Color provides a genetic counselor that you could speak with about your results. The last method is through something like a clinical trial. For example, there's a PROMISE registry that's available for individuals to get genetic testing at no cost. The way that genetic testing is facilitated is you enroll into a registry, which is basically just a group of people who have something in common, and that being that they have prostate cancer and they are going to be getting genetic testing. And then the clinical trial will facilitate the genetic testing, and then there'll be options for genetic counseling after as well. So these are the different kind of avenues: referral-based process, a physician-initiated process, a patient-initiated process, and then joining clinical trial. Four kind of general routes that are there.
Thank you. And we'll hear a little bit more about these clinical trial options later. Dr. Sokolova, what mutations are found most commonly as a result of testing, such as, we've heard of often BRCA1 or 2, but tell us, I know there are more and it's hard to keep track of. Tell us more.
In prostate cancer, the most common mutation that we do find is BRCA2. That's the most, I would say, impactful mutation and the most common one. It's followed by ATM and CHEK2, BRCA1, and then there's a plethora of other ones that are a little less prevalent, PALB2, RAD51, ATR, NBN, PMS2, to name few. But I would say the BRCA2 mutation, it's the most prevalent, and it's the one we understand the most, the one that responds to our targeted treatments the most. Out of all kind of DNA damage repair mutations in germline setting, it probably represents about 40-ish%. BRCA2, and then the rest 60 is shared between the rest of mutations, with ATM being around 13%, CHEK2 being around 12%, BRCA1 being around 7%.
Great, thank you for that. So let's talk, you mentioned treatment, so let's talk about that. What are the implications for treatment for patients?
So the treatment implications are standard of care or clinical trials. And a clinical trial is a very fast evolving space, and it will be depending on location or particular time. So I would say you should always talk to your doctor about what are the clinical trial implications for this testing. Do you have anything if I were to find a mutation? If we talk about standard of care, then there's two potential implications. If we find anything in our kind of microsatellite instability, mismatch repair deficiency, Lynch syndrome genes, then immunotherapy is effective. And immunotherapy is one of the first drugs that was approved tumor agnostic. For any cancer that has those mutations, this treatment will work. It has an FDA approval. So that's kind of our one bucket. And the second bucket we have is PARP inhibitors. So PARP inhibitors is an oral medication that uses cancer's inability to restore DNA damages by knocking out the second mechanism to restore DNA damages. So, and with two DNA repair mechanisms disabled in the cell ends up dying. And so tumors that have one of those mechanisms paired, so have BRCA2 mutations, BRCA1 mutations, ATM mutations, they end up not surviving, knocking out the second DNA repair mechanism by PARP inhibitors. And there's quite a few PARP inhibitors approved right now. The first approval was in a second-line metastatic castration-resistant setting. So folks that have had already chemotherapy, have had AR-targeted drugs, and now kind of moving to a second-line metastatic castration-resistant, and both olaparib and rucaparib approved in that setting. And most recently, I would say within the last 4 to 6 months, we've had several FDA approvals in first-line metastatic castration-resistant setting of PARP inhibitors for patients with certain mutations. And if someone only had hormonal shots or only hormonal shots and chemotherapy and kind of haven't seen those newer hormonal drugs in a first line, when they progress, then in a first-line castration-resistant setting, they could use a combination of those newer hormonal drugs, abiraterone and enzalutamide type drugs, in combination with a PARP inhibitor. And we have olaparib, talazoparib, and rucaparib in that setting, and use it in combination, this kind of first-line metastatic castration-resistant setting for folks with BRCA1, 2 mutations. is another FDA setting. I don't remember if we talked or not, but about 20% of patients with metastatic disease have those mutations in a somatic setting. About 12% have in germline setting. So overall, kind of 20 to 25% of people would be eligible for those treatments. And that's why we should be doing this testing.
Great. Thank you for that. It's exciting that these drugs have come on the market and given patients more options. Justin, if there is an important genetic finding, what are the implications for the individual and their family?
Yeah, and so as Dr. Sokolova mentioned, a germline genetic test result, when we find these, there's broader implications compared to the tissue or the somatic genetic testing, where it's kind of very much treatment focused. And there's overlap, because if someone does have a germline genetic predisposition, all the medications that Dr. Sokolova mentioned, that person would be eligible for. And it would just be depending upon what type of mutation they have, if they have cancer, whereabouts they are in their diagnostic journey, the eligibility. And so there's that piece about if someone's diagnosed and they're diagnosed later on, and there's this question of systemic therapy. A lot of the things that Dr. Sokolova mentioned are applicable to people who have these germline genetic findings. But then there's this kind of question about, well, what if someone doesn't have metastatic disease? Does this genetic finding have any implications? And then Dr. Sokolova mentioned the BRCA2 gene, which is, again, a gene that's very, very well studied in the context of breast, ovarian, prostate cancer. And we know that individuals who have this gene, if they do develop prostate cancer, their prostate cancer acts differently than prostate cancer in the general population. And so it may get some people who are oncologists who are treating local cancer to say, hey, should we take a more aggressive approach in treating, as opposed to the more kind of a less aggressive approach that we would do maybe for someone in the general population? There's not a lot of evidence or data to suggest that people should be changing practice when it comes to local prostate cancer, but something that you could have a discussion with, and that your oncologist may be able to talk with you a little bit more about, and may change some approaches, they may not. And if we were to go even lower in the diagnostic pathway for someone who has a very low-grade prostate cancer and is on something like active surveillance, and they're found to have a BRCA2 gene mutation, there might be some evidence to suggest that people on active surveillance with BRCA2 mutations, they may not stay in active surveillance too long. Their prostate cancer may upgrade or get to a point where they would need a medical intervention sooner. And so maybe there might be some more evidence to say, is BRCA2 something that we need to be factoring in when people are on their active surveillance journey, if they have that in the germline. So those are implications for them when it comes to their own diagnosis of prostate cancer. But if someone has a germline mutation, and again, it's inherited from the sperm or the egg, so that means that that mutation would be present in every cell in their body. These genes, their job is to repair DNA. And in certain tissues, they do that more often. And repairing DNA is really important, because if our cells don't repair DNA, our cells can accumulate mutations. And if you get the wrong mutations and the wrong genes, they can start becoming cancerous. So when it comes to a gene mutation like BRCA2, BRCA1, PALB2, if someone has a mutation there, they're not only at risk for prostate cancer, but breast cancer. They're at elevated risk for pancreatic cancer. There's more evidence to suggest that there might be an elevated risk for stomach cancer. In women, people with ovaries, we see risk for ovarian cancer. The other genetic condition that was mentioned is Lynch syndrome. And so we see elevated prostate cancer risk in these individuals, but we also can see increased risk for colon cancer, uterine cancer, ovarian cancer, some genital urinary cancers. And so it might make us think, hey, if you have this gene mutation, prostate story, we got this under control. Now we have to start screening for other things that could be connected to this gene. So that's the individual. When it comes to the family, then we start thinking, okay, well, if this, again, cell's present in every cell in our body, if this gene mutation is present in every cell in our body, when it comes to our germ cells, our eggs, our sperm, 50% of them have the gene mutation. So that means there's a 50% chance this germline mutation is passed on to the next generation. So family members can get genetic testing to see if they have inherited this. And we think about our parents. Well, we inherit it from either the egg or the sperm. And so either a biological parent may have passed this on. And then we think about siblings, and we think about cousins, and then we think about nieces and nephews. And so it becomes a big family thing where we can say, hey, if you are unaffected by cancer, but you have this gene mutation, let's start screening you early. The NCCN just came out with guidelines saying if you have a BRCA gene mutation, BRCA1 or BRCA2, let's start PSA screening at age 40 every year. And so these guidelines and recommendations and rules are there for every cancer associated with every gene that we know today. And so it can become something that impacts the whole family pretty quickly. And it's an important thing to talk about so that, sometimes people are going and getting genetic testing because it's going to help their management. And then after everything's said and done, they sit back and think, okay, how am I going to talk to my kids about this now? And how am I going to talk to my siblings about this now? Because there's a 50% chance that this might be a part, or that risk for cancer might be a part of their life story too.
Thank you for that rundown. That was really helpful. And I think just to put a plug in, I know you both would agree with me. It's important to talk about this and talk about the family history and who, grandma had what type of cancer and when was she diagnosed and, and so, talk about all of this so you can be informed and then have these conversations with your doctor.
Yeah, and family history directly informs your personal management. And so if you don't have cancer, but you have a parent or a sibling who has had, for example, colon cancer, then if you tell your family doctor, hey, my brother had colon cancer, your doctor is going to think about your risk for colon cancer differently, might increase your screening. And so family history is really important and does change how the healthcare system perceives you and oftentimes gives you more access to services.
Good point. Thank you. So, Dr. Sokolova, final question for our panel here before we go to audience questions. And we've talked a little bit, Justin alluded to this a bit too. Are there clinical trials available related to germline or tumor testing? Tell us more about those options.
I will start by piggybacking on Justin's discussion about cascade testing. I cannot emphasize this enough how important it is for both men and women to get family cascade testing. And I would say, unfortunately, historically, we've called it hereditary breast and ovarian cancer syndrome. We've excluded men. And I think there's this kind of perspective that this is less relevant for men than it is for women. Or some men with prostate cancer think, oh, it's important only for my sons, not for my daughters. It is equally important for female and male family members. And one of the clinical trials that I did want to highlight today is one of the trials that we run here at OHSU, but available nationwide. It's about cascade testing, and it allows us to help do the testing in the families. So we take the burden off the patients, and patient says, hey, please talk to my son, my daughter, my sister about that they need their own testing. And so we reach out directly to them. We educate them about why they need it, and then we provide a free testing for them. And it's all done remotely. We talk to our participants over the phone, and we just mail the testing kits to their house. So if any of you still have family members that you kind of haven't approached or want to talk about, there would be some links associated with this talk that you can reach out and kind of direct them and to our study to do that. As far as studies, how to do the testing itself for the patients, one of the big studies that we've talked about, it's called the PROMISE, Prostate Cancer PROMISE. The beauty of this study is that you don't have to meet NCCN guidelines. You don't have to be thinking, or do I meet this particular criteria or not? If you have a prostate cancer diagnosis, you're eligible, period. So if you have a prostate cancer diagnosis, localized, high risk or low risk, biochemical recurrent or metastatic, you would be eligible. You can do it from the comfort of your home. You go online, you fill out some questionnaires, and there's quite a lot of questions, so there'll be some time dedication to that. But then again, the study team reviews your responses, and then they send the testing kit to your house. You spit in the tube, you put it in your mailbox, and you send it out, and then they call you with the results. So the study tries to remove a lot of barriers for our patients to get the testing done. And so those are one of the studies about the testing itself. There's also a lot of clinical trials around implications. And the two ones I want to highlight in an earlier setting. So when we talk about people with localized prostate cancer, at this point in time, there's no treatment implications for people with mutations with localized disease. But there's two clinical trials right now available in the US that offer treatment on a clinical trial basis. The Neptune trial offers neoadjuvant PARP inhibitors for those patients. So if you have a high-risk localized disease and you have BRCA1/2 mutations, you would be eligible to get a PARP inhibitor for 6 months, and then you go for surgery. And the second trial is a SWOG 2210. It offers chemotherapy, carboplatin chemotherapy for the same patient population. So people with BRCA1/2 mutations and a high-risk localized disease, before going for surgery, they'll get 3 to 4 cycles of chemotherapy. And the hypothesis of both those studies is those patients with mutations, they have a risk of more aggressive disease. They have a poor prognosis. So trying to kind of really attack it with targeted treatments early on and then take them for surgery, hopefully will maximize the chances of cure.
Great. Well, that's exciting too. Not only to, we've partnered with the PROMISE study, so I think some of our viewers are probably aware of them and their work, but thank you for highlighting them. That's eligible to, as you said, all patients diagnosed with prostate cancer, but then it's exciting to hear about some of these other options too, as well. So now we will go to our audience questions. So remember, you can still get those in. You can even put them in the chat. They're featured on YouTube. So first question is, I am almost 2 years into treatment for Gleason 9 localized EPE, which is, they say, proton therapy plus ADT and abiraterone. My oncologist is at a major medical center, hospital, but has not mentioned germline or somatic testing. At what point in my treatment should this testing take place?
I'm happy to take that. I would say you can talk to your oncologist about this testing now, because you do have a high risk, so you meet the germline testing criteria. Somatic one, I think it's a little tricky. Currently, kind of the guidelines don't recommend it, this disease space. On a case-by-case basis, we sometimes offer it if we think there's a really high chance of recurrence. But I would say germline testing you can definitely do, or you can just go ahead and click on the PROMISE link and kind of do your study. But you're definitely eligible for germline testing, and you can have it done now.
Thank you. We have one other, I'll ask this, but I'm not sure. This is a very advanced question. What effect does high ferritin, and we can keep it brief and as relevant to prostate cancer, I guess, as we can. What effect does high ferritin, whether from hereditary hemochromatosis or otherwise, have on prostate cancer inception and development? Go ahead.
This might not be my best world in that I'm not an oncologist. But yeah, there's many reasons for why someone might have high ferritin. I can speak to the hereditary hemochromatosis. When we think about hereditary hemochromatosis, I don't think about anything related to elevated risk for cancer. Hereditary hemochromatosis is a condition that you can treat just by doing a phlebotomy, giving blood. And so an altruistic gift to society, as well as decreasing your ferritin levels, but maybe trying to understand what the underlying causes of the elevated ferritin, whether it is a genetic factor or some of the other factors that can cause your ferritin to be elevated. But to my knowledge, individuals with hereditary hemochromatosis are not at an increased risk for cancer.
Okay. Thank you. Well, we will go to our sorry. So we've got all the time we've got for questions. Of course, you can continue to submit those, and we can try to help out with those at a later time. But we've coming up in just a few minutes. It's our Ask the Experts Q&A panel with Dr. William Jackson and Dr. Randy Vince. We want you to be part of this discussion. So again, email us your questions now at education@zerocancer.org. We've already seen quite a few questions come in for this one, as it's a broad conversation. It's really just all audience questions, so it's sure to be a lively discussion. Before we take a quick break, I want to say thank you to our premier sponsor, Pfizer Oncology. I'd also like to thank AstraZeneca, Bayer, and Johnson & Johnson for being our platinum sponsors. You can learn more about all of our sponsors in the sponsorship tab here on our virtual summit website. And as we head back into the break, here's a video from one of the sponsors we just mentioned, Johnson & Johnson. We'll see you back here at 2 p.m. Eastern Time. Thank you.
Hi, everyone. It's wonderful to be part of this important event. I'm Chumi Kurana, Vice President of Sales and Marketing, Solid Tumor in the Oncology business at J&J Innovative Medicine. We are so proud to sponsor the Zero Prostate Cancer Virtual Summit and proud to work alongside the prostate cancer community. Inspired by our patients at J&J, we are leading where medicine is going. Prostate cancer is an important focus of our company, and we have a lot of exciting work underway that builds on a decade-plus legacy of innovation. Our goal is to get in front of prostate cancer as we work on the next wave of therapeutics with highly selective targets and advance a patient-centric development program spanning the entire disease continuum. We are also relentlessly committed to patient well-being, achieving strong clinical measures, but also measures that go beyond therapy as we address gaps in health equity. Working through community-based initiatives, we're reaching underserved populations with critical information to drive testing and better outcomes. Every part of our work, from clinical advancement to patient education and awareness, is critical in reversing the hold that prostate cancer has on far, far too many men. We also recognize something very important. We can't end prostate cancer alone. This is why we're so honored and incredibly grateful to partner with Zero and so many other wonderful organizations and patients in the prostate cancer community. It is important for us to listen to patient voices, to better understand challenges, and to ensure that our work is meeting real patient need. This helps us work on our mission to reimagine care so that patients can redefine living. Thank you to Zero for hosting this event. Our time and work together matters deeply to someone who faces prostate cancer. Have a great night.
Welcome back to the virtual Zero Prostate Cancer Education and Support Summit. I'm Jeremy Patch, Zero's Director of Patient Programs and Education. I'm excited about our Ask the Experts Q&A panel, and I know you are too by the number of questions that are coming in. But I want to make sure you check out our on-demand section after we wrap up our live sessions today. There are a number of videos we've been spotlighting over the last few days, but here are a few we want to make sure you know about. Learn why advocacy is crucial, how to get involved, and how it can impact patient rights and access to quality healthcare in a video from our premier sponsor, Pfizer Oncology. In a video called Know Your Numbers from Astellas, men from various walks of life open up about their journeys with prostate cancer. We also have an informative overview of biosimilars in a video from Sandoz. Finally, we have a video on how active surveillance can benefit patients who are newly diagnosed with low-risk prostate cancer from Blue Earth Diagnostics. All of these videos and more are in the on-demand section of our Summit website. But before you click on those videos, it's time for our Ask the Experts Q&A panel with Dr. William Jackson and Dr. Randy Vence. Dr. Jackson is an assistant professor in the Department of Radiation Oncology at the University of Michigan. He performed his residency in radiation oncology at the University of Michigan and subsequently joined the faculty upon completion of his training. He serves as the co-chief of the genitourinary radiotherapy program. Dr. Jackson's research focuses mainly on improving outcomes for men with aggressive or recurrent prostate cancer. While he's not yet with us, we're hoping to have Dr. Vence join soon. Dr. Randy Vence is the Director of Minority Men's Health at the Cutler Center for Men at University Hospitals and is an Assistant Professor of Urology at Case Western Reserve University. Dr. Vence actively participates in research and community outreach events to promote health equity and eliminate healthcare disparities. And I want to acknowledge that a scheduled panelist had something come up, but was helpful in securing Dr. Jackson to join this panel. So Dr. Jackson, I know at this time yesterday, you didn't know you would be doing this. So we're grateful for your time today. Welcome. So I want to jump as we hope Dr. Vence joins us soon, but I'm going to go. This is all really audience questions that have been submitted to this point. And I know this is always a really hot, exciting panel that people want to hear from. They really just, our patient community has a lot of questions. And so we're excited about this to get to those questions today. I'll go to question for you on, since you are do radiation oncology, please discuss when IGRT, and you can help me kind of explain what these are. IGRT may be more beneficial than IMRT for patients with rising PSA after radical prostatectomy.
So yeah, that's a great question. And so just to kind of define these terms, so IGRT stands for image-guided radiation therapy, and IMRT stands for intensity modulated radiation therapy. And these are not mutually exclusive. So I think most major academic centers in the United States would be treating with a combination of both of those. So image guided typically refers to taking a mini CAT scan prior to each treatment to make sure that we're perfectly aligned to the targets that we're treating, which for a man who has a rising PSA after prostatectomy is typically the prostate bed plus or minus the surrounding lymph node chains. And that pre-treatment scan allows us to make sure that we are perfectly targeted in where we're trying to treat. We also typically treat men with a full bladder and ask that they've tried to have a bowel movement that day so that they don't have an excessive amount of gas or stool in the rectum. And so that scan really allows us to make sure that the patient is perfectly set up for treatment. IMRT really refers to just treating very precisely and conformally with millimeters of accuracy. And so I would say that for the majority of men being treated in that situation for a rising PSA after surgery, that having both of those is a key component to treatment.
Great. Thank you for that. There's a couple of questions about Pluvicto. So do your best to answer this. How much, and And tell us, I guess, well, first, how much improvement can be expected from lutetium LU177 or Pluvicto treatment? And are there any stats that show the on average improvements and the effectiveness of the treatment?
So what I would say that is, yeah, so Pluvicto is definitely an emerging therapy that has been proven to date to be very effective in men who have metastatic prostate cancer that no longer responds to hormone therapy, or metastatic prostate cancer that has progressed through hormone therapy. And so what Pluvicto is essentially there are new scans for prostate cancer, which are called PSMA PET scans, or prostate-specific membrane antigen PET scans. And what those scans do is essentially they inject a radiotracer that binds to kind of the specific marker PSMA on prostate cancer cells. What Pluvicto is doing is then tying lutetium, a radioactive substance, a very small substance, to that same tracer, so that essentially when that tracer binds to the prostate cancer cell, it delivers that focal radiation. And for men with metastatic castration-resistant prostate cancer, this has been proven to improve responses and longevity compared to other standard of care treatments, and is definitely an active area of investigation for men who have earlier stages of prostate cancer, whether that's newly diagnosed metastatic prostate cancer that is still sensitive to hormone therapy. And there are even studies going on for men who have kind of newly diagnosed very high-risk prostate cancer as well.
Thank you for that. A secondary question now about that treatment. A patient says, we were thinking that Pluvicto would be in the near future, but we are now hearing as a possible treatment option for them, but we are now hearing there's a shortage affecting enrolling new patients in this treatment. What can you tell us about that?
So there was definitely a shortage, I think, mid last year as the first FDA approval was gained. My understanding is currently that has significantly improved, and a lot of major academic centers now have access to this pretty routinely. I think there is a hope that at some point later this year, there will be approval for men who have hormone-sensitive prostate cancer, which then could make shortage concerns arise again. But I would definitely reach out to kind of surrounding larger centers to see if they have availability.
Thank you. What can you tell us about the clinical research on the alpha particles?
So yes, so this is kind of going one step beyond or very similar to what Pluvicto is. It is essentially using a radiotracer that uses a different form of radiation, which I would say is kind of, just to conceptualize, using a ping pong ball versus a bowling ball. But that bowling ball doesn't go very far. And so the bowling ball can be more effective, which is the larger molecule in really delivering radiation locally to the prostate cancer, but having less off-target effects. And that is open. There's a lot of trials ongoing looking at actinium, and it's definitely an active area of investigation.
Okay, thank you. You had mentioned hormone-sensitive prostate cancer, and hopefully that Pluvicto might be available for that. I believe you said. Why are the question is, why are some treatments unavailable to those with hormone-sensitive prostate cancer? Don't we want to use these earlier?
That's a great question, and I think we do. The way that essentially approving medications work in the United States, and honestly most of the world, is that there has to be large clinical trials that support the use of the medication, that demonstrate a benefit. And so there have been ongoing large trials of, for example, Pluvicto in men with metastatic hormone-sensitive prostate cancer. And the company that makes Pluvicto is actively working with the FDA to gain approval for that. But until the FDA approves the medication in the United States, it is hard to gain insurance approval without that approval first from the FDA. I would like to get proton treatment for my prostate cancer.
I have 2 hip replacements though. Can I get effective proton beam treatment if I have hip replacements on both sides? Also, what are your thoughts about proton treatment?
So proton therapy is a form of external beam radiation therapy similar to photons or X-rays, which has really been the standard external beam radiation therapy for decades. There is a theoretical benefit of proton therapy in that it may reduce the amount of radiation to surrounding normal healthy tissues. For men with prostate cancer, there is no convincing data to date that proton therapy either improves outcomes or reduces side effects compared to photon or X-ray therapy. The reason for that is probably multifactorial. Some is that where the prostate sits, the bladder physically touches the prostate and the rectum physically touches the prostate. So no matter how precise you are with proton therapy, you are still delivering some radiation dose to the rectum and bladder, just like you are with photon or X-ray therapy. The other is that with X-ray or photon therapy having been around much longer, the treatment machines that deliver those tend to be able to do so in a much more precise fashion. And so some of those theoretical benefits of proton therapy just have not been realized. I have never referred a man specifically for proton therapy for prostate cancer. There are rare instances with like children with brain tumors where it's critically important to spare any amount of normal healthy brain where protons can be very effective. I don't think that there's anything wrong with being treated with proton therapies, but I don't think that any man needs to be seeking that out specifically. And I think that the question about the hip replacements would depend on the individual center and the technology that they have available with the protons.
Okay. They can talk to their doctor if they, have more, certainly, questions about that. When may, if you can answer this, when may ultrasensitive PSA trending be more beneficial than normal PSA trending?
So that's a good question, and I don't think we know the answer to that yet. So for a long time, a lot of institutions across the country, the lowest PSA threshold that they were able to detect was 0.1. And for men who have a prostate who have not had surgery or not had radiation therapy, I think that that's a very reasonable test. I don't think that having additional data beyond, a single decimal point, I don't think that there is a clinically meaningful difference between a PSA of 4.1 or 4.2, for example, as opposed to 4.15 or 4.25. There may be rare instances, though, for men who have had treatment where being able to truly detect lower levels of PSA could be beneficial. One could be men who have had a prostatectomy where their PSA should be 0. And if the lowest level you could detect was 0.1, there might be some advantage into knowing sooner whether the PSA was a 0.05, which would not register if the lowest you could detect was 0.1, and that would be considered an ultra-sensitive PSA. And so I think it's an active area of investigation, but I don't think we have a clear answer to the exact situations where that is beneficial. I will occasionally use it in men who have very high-risk prostate cancer, who have had surgery, whose PSA on our assay that we use reads less than 0.1, just to get a sense maybe there is a little bit of residual prostate cancer. But that is more of a personal practice as opposed to something that is supported and encouraged by national guidelines.
Thank you. Do we know what it is about testosterone which promotes prostate cancer growth and spread?
So we do know a fair amount about what testosterone does and how it drives that. And it turns out that really what testosterone does is that it activates prostate cancer. So on prostate cancer cells, testosterone, which is the male hormone, and androgen binds to what is called the androgen receptor on prostate cancer cells. And that kind of binding of testosterone really drives prostate cancer growth, proliferation, and the ability to spread over time. And that is something that has been very, very well studied and very well established. And so we feel very confident in the fact that testosterone definitely can drive and promote prostate cancer.
related question. When, if it sounds like if someone is metastatic and when castration resistance happens or hormone resistance happens, do we know how the cancer mutates and what drives the growth or spread instead of testosterone?
So that's a very good question. Yeah, we know that most prostate cancers eventually will learn to outsmart being deprived of testosterone and will start to grow again in that setting. And I think there are a couple of well-established different mechanisms that prostate cancer does that. Sometimes prostate cancer will learn how to produce its own testosterone, or it will learn how to kind of activate those same pathways that are activated by testosterone in the absence of that. And sometimes it just becomes kind of almost a completely different cancer where it is just independent of testosterone altogether. But again, is a very active area of research so that we can better understand kind of new treatments to help men who become resistant to our standard hormonal therapies.
Thank you. Just reviewing the questions here. There's a couple of questions related to diet. I'm gonna throw these at you, and you do your best. And just for context, we had a conversation yesterday. One of the discussions was on a plant-based diet, the benefits that it can have for prostate cancer patients. So probably some carryover maybe. This person says, when I eat the recommended number of grams per day of vegetable protein, such as legumes in combination with whole grains and fruits, my blood sugars tend to spike above 140. I am not diabetic and have normal A1C and fasting blood glucose levels. Given that prostate cancer thrives on, and maybe you can confirm this, given that prostate cancer thrives on elevated glucose and insulin levels, should this be a concern?
I would say probably not. So I think in general, prostate cancer, different than a lot of other cancers, does not tend to be as sugar driven, tends to be more testosterone hormonal driven, kind of a female equivalent is breast cancer, which is also a very hormonally driven cancer. And so I very much agree that a plant-based diet or just any sort of cardiac healthy, heart healthy diet can be beneficial. And part of the reason for that is for a lot of men diagnosed with prostate cancer, they're much more likely to die of kind of other causes of death than prostate cancer. And so just kind of maximizing your overall health can become very important.
Similarly, there's a question about what benefits they can have by for their prostate cancer, can they have by eliminating glucose and glutamine?
So yeah, so removing exact substances from the diet is a little outside of my area of specialty. I don't think that there's great evidence that completely removing glucose is of benefit, other than that, again, removing high sugar foods from our diets is healthy and beneficial for almost everyone, independent of prostate cancer. And I can't speak intelligently to the glutamine question.
Thank you. This person says we are opting for radiation treatment with 2 years of hormone therapy. Can any of the ED treatment options be used during those years, or must all ED treatment wait until post-therapy?
No, you can absolutely try erectile dysfunction treatments while you're on hormone therapy. So hormone therapy for almost all men comes with a loss of libido. It technically does not mean an inability to achieve an erection, but the majority of men who are on hormone therapy say that when that interest goes away, they have a hard time having an erection. But it is absolutely okay to try, whether it's pills like Viagra or Cialis or injections or pumps or any other devices. That will have no impact on the outcome of the treatment overall.
Okay. Does that go for like physical therapy, pelvic floor therapy as well?
Correct.
Okay, great. Thank you. Is SVI involvement, and again, you can tell us what that is, considered METs? And if so, what should I consider? The main goal, this patient does not want incontinence.
Okay. So SVI stands for seminal vesicle invasion. And so the seminal vesicles are two little glands that are almost like rabbit ears off the backside of the prostate that help produce seminal vesicle fluid, ejaculate fluid. And so invasion of the seminal vesicles, as evidenced typically on either an MRI or a PET scan, is indicative of high-risk prostate cancer. And all that typically means is that as long as that individual man is in good health, we absolutely recommend treatment. And typically the two treatments are either surgery or radiation therapy with 18 to 24 months of hormone therapy with the radiation therapy. Those treatments are different logistically and side effect profile wise, but we think that they're potentially equally effective. Radiation therapy in general does not tend to come with a risk of incontinence. Surgery usually comes with a transient risk of incontinence, but most men by a year after surgery are no longer having incontinence.
Okay, thank you for that. Will immunotherapy work, or does immunotherapy work in bony metastatic prostate cancer?
So immunotherapy is a form of systemic therapy that is really trying to rev up our own immune systems to fight cancer. And there are some cancers where we've actually had a lot of success with this. To date, prostate cancer has not been one of those prostate cancers. We have not had much success using immunotherapies to really improve outcomes. That being said, there are definitely, many clinical trials going on trying to figure out ways in which we can kind of essentially make prostate cancer sensitive to immunotherapy. So there are a lot of clinical trials out there, and I think if that is an option, it's definitely something worth considering.
Are you aware of the DAPPER clinical trial at the Mayo Clinic?
I am not off the top of my head. I could look it up very quickly.
Well, that's the question is just who may this trial benefit, but that we can put a pin in that.
Okay.
I don't want you to have to do your homework right on the spot. But thank you. Yeah, I just took a shot there. Here's what this patient, I'm going to paraphrase what they're saying. I have been experiencing neuropathy for a 2-year period after prostate removal surgery and follow-up radiation. It has been suggested that I try dorsal root ganglion stimulation, but I am hesitant about another surgery. Do you have any thoughts about this procedure or another avenue to treat the neuropathy? So
that is a little outside of my field of expertise, so I might pass on that one.
Okay. Yeah, that sounds like a specific to neuropathy. So maybe talk to their doctor and follow up more. Today we heard that our previous session was on germline and somatic testing, genetic testing overall. We heard earlier that all men with metastatic prostate cancer should get both germline testing and somatic testing. Again, that's men with metastatic prostate cancer. What could be the reason for an oncologist or physician not recommending somatic testing to a metastatic castration-sensitive person with prostate cancer?
I don't know why that wouldn't be recommended. I agree in general. I think for men with metastatic prostate cancer, testing both somatic and germline mutations is a standard of care and recommended by most guidelines. There may be nuanced situations for any particular individual where, the potential risks and benefits of somatic testing may be considered, but it's hard for me to, hypothesize on that without knowing the specific situation.
And this sounds like an opportunity for this person to maybe talk to their doctor about this on a panel. I heard a discussion. This was recommended. can I please, get genetic testing? Yeah. Certainly, and that's why we're doing all of this, right? To empower patients, to give them these, some guidance, so maybe they can go back to their doctors and have these individual conversations.
Absolutely. And I think that's, an incredibly important point that, every patient out there should feel comfortable going to their physician with these questions.
Agreed. There's a question here. It's related to some of the earlier questions about testosterone and its effect and how it impacts prostate cancer. So why does it seem like oncology for prostate cancer patients seems to be satisfied by essentially turning a large part of, or turning some of these patients into eunuchs with chemical castration to starve the prostate cancer instead of actually trying to kill the cancer? I know the chemotherapy has its own side effects, but why does it seem like there is little to no research in this area for prostate cancer, or that they're hearing about, maybe?
So I think there is a lot of research in that area. I think as, a radiation oncologist, but my colleagues in medical oncology would definitely agree that, the vast majority of men would prefer not to be on indefinite or even intermittent or some prolonged course of an anti-testosterone hormone therapy. The reason that it's the standard of care currently is that all of the clinical trials that have been run in the United States and all over the world still support that that is how we help men live the longest. Chemotherapy has been, honestly not all that helpful for men with even kind of early metastatic prostate cancer. The data really supports that it's most beneficial in men who have really failed hormone therapy or who present with kind of metastatic prostate cancer throughout the body, a very high volume of prostate cancer. And it doesn't seem to add much benefit in earlier settings than that. But there are definitely, tons and tons of trials going on trying to figure out ways that we can either shorten hormone therapy or replace hormone therapy with other things. But prostate cancer being so testosterone, so hormone driven, to date, that is where we have had the most success.
Thank you. Again, this is a diet-related question that, but is it beneficial to reduce dairy and eggs and meat with advanced prostate cancer? And I would encourage everyone to go look at the talk also from yesterday. It will be, if it's not there, it will be posted on our on-demand section soon. But do you have any thoughts on the benefit to reducing dairy and eggs and meat for advanced prostate cancer?
No, I would definitely agree to refer to the talk on nutrition from earlier. But I would just say, I think, in general, everything in moderation. I don't think that you need to be trying to do anything in excess, and in general, avoiding anything completely. But I think moderation, just trying to have a healthy, well-balanced diet overall is beneficial for everyone.
I think we're coming to a lot of end of a lot of our questions, and I want to thank you, Dr. Jack. I know, again, we talked about you weren't expecting to be here, and then you do all the heavy lifting. So thank you so much for joining us and for lending us your time and expertise. I do want to give you just one final, since you are a radiation oncologist, is there anything you'd like to say about radiation, or just some education that you'd like to do about radiation for us, or just tips on even how to talk to your doctor if you're trying to decide between maybe radiation and if you're early stage and trying to decide between radiation and surgery.
No, that's a great point. And thank you so much for having me. It's an absolute privilege to have the opportunity to talk with all of you today. What I would say is that for any man who has localized or even kind of regional prostate cancer that has spread to pelvic lymph nodes or is contained to just the prostate, I would strongly encourage any of those patients to meet with both a surgeon and a radiation oncologist. I think it is really important to hear both of those points of views. The University of Michigan, we have a multidisciplinary clinic where you meet with both of us at the same time. I like that for patients because it keeps all of us honest. We're all sitting in the room together. But I think it really is important to have those conversations because for a lot of men who have kind of earlier stage prostate cancer or kind of earlier diagnosed prostate cancer who require treatment, we really think that surgery and radiation therapy and sometimes adding hormone therapy with radiation therapy are equivalent treatment options. We really do think that the likelihood of long-term cure of not having to deal with your prostate cancer again is the same with either of those approaches. The treatments are very different logistically and side effect profile wise. That being said, the vast majority of men do really well with modern surgical techniques or modern radiation therapy techniques, but it's really just good to understand what the options are for you. And I really view our job as physicians is to help kind of educate and empower patients so that they can make the treatment that is right for them. And that's going to be different for every single man. And so it's really important to understand what your options are and make sure that you're making the treatment decision that fits you best.
Thank you. I appreciate that. We definitely encourage second opinions or as many as it takes. And I would even add, if you're still struggling with the decision, a medical oncologist as well, seeing them can help kind of provide some additional guidance, perhaps. So
absolutely.
Yeah. I'm going to ask you, we do have a few more questions that have come in now, and they are specific to radiation. So my radiation oncologist is recommending a combined external beam and temporary seed implant, or otherwise known as brachytherapy, is a common method. Is this a common method of treatment?
It is a common method of treatment, particularly for men who have more aggressive or say high risk localized prostate cancer. That is very much a standard of care treatment option and has been shown in the long run to reduce the risk of a PSA recurrence. It has not shown to, on average, improve how long men live, but has been shown to reduce the risk of the PSA ever rising in the future with that combination.
Okay, thank you. Is any type of radiation therapy feasible as a salvage therapy following radiation and ADT if a PSMA scan shows the recurrence is localized to the prostate?
So typically, there are two radiation options. One is brachytherapy, which is treatment with internal radiation. The other option is potentially something called stereotactic body radiation therapy, or SBRT, which is just giving very kind of focal high dose radiation over typically 5 treatments over the course of 2 weeks, typically every other day. What I would say is that for any man who's in that situation, who's had prior radiation therapy and then has, a PET evidence of recurrence, I think that getting a biopsy to prove that recurrence is important. And then making sure that you're seeing at a really high volume center that's going to have expertise in reirradiation, because anytime we're doing radiation therapy a second time to the prostate, it potentially comes with significantly higher risk than the first go round.
Okay. Well, thank you for answering the final questions. And again, thank you so much for joining us today.
No, it is my absolute pleasure. Thank you so much for having me.
Thanks, Dr. Jackson. The last 3 days have flown by. Thank you to all our speakers and our participants. We appreciate your time, your insights, and your interest in learning more about prostate cancer. As our CEO, Courtney Buechler, said in her welcome message earlier this week in reference to a conversation she had with an oncologist, empowered patients make better doctors. We hope the last 3 days have empowered you, all of you, as you navigate your prostate cancer journey. You can expect 2 things in the coming days and weeks. Please be on the lookout for an email containing our survey. We respect all your opinions about this virtual summit. This survey will help us make our next summit better and more informative for everyone in the prostate cancer community. Also, all registered participants will be getting a thank you package in the mail. There will be some things from Zero and our sponsors in there, and you can expect that in early April. Thank you again to our premier sponsor, Pfizer Oncology. I'd also like to thank AstraZeneca, Bayer, and Johnson & Johnson for being our platinum sponsors. Thank you as well to our gold, silver, and bronze sponsors. They're all listed in the sponsors tab here on our website, and their support allows us to bring this information to you, so thank you. I'd also like to thank Bayer again for helping Zero bring you our fantastic keynote speaker, Deborah Roberts, and if you missed that, please go check her out. It's a message of hope. Finally, while this is our last live session, there are so many great sessions for you in the on-demand tab of our virtual webpage. Not only are there new topics for you to review, but all of our live sessions are being posted there as well. On that page, you'll have access to all of those videos through the end of March. Thank you again for being part of the virtual Zero Prostate Cancer Education and Support Summit. Have a wonderful day.